Am I audible at the back? Yeah, thank you. I would be talking on advances in perioperative pain management in cardiac patients. Well, I started my career at Sri Chitra Institute, Trivandrum, and you may be wondering why I'm showing this picture. The reason is that when I started cardiac anesthesia practice, the analgesia was totally narcotic analgesia, that's morphine and only morphine. And from there, I moved on to AIMS Raipur. And fortunately, you see, I was shaping the department of anesthesia, not cardiac anesthesia, the department of anesthesia. And fortunately, we selected one of the chairperson, Dr. Samarjit. And he's so good in, you see, the pain medicine, chronic pain, acute pain, etc., that I took a lot of, you see, I would say, lead from the way he used to manage the patients, blocks, etc., that I felt that future for anesthesia is blocks. It's not the narcotic analgesia. The future in anesthesia is excellence in blocks. In fact, I have seen some of the patients where I felt that it would be very difficult to give anesthesia, and those patients were managed by Dr. Samarjit under some or other kind of block. So it was so fascinating, and so you see it changed my thinking about analgesia, perioperative analgesia, and I felt that you see the blocks, etc., has to be the integral part of management. So from there I moved on. I retired from AIMS Raipur in 2020, and from there I moved on to Amrita Institute, Kochi. And there when I joined, the practice was same narcotic anesthesia. But I felt that a block should be the part of it, and that's why all these photographs, that I made sure that all the cardiac patients, they receive one or other kind of block. And by the time, you see, it was 2 years for me there in Amrita Institute, all the patients, they were receiving ESP block, whether it is a neonate or it's an elderly patient, unless the patient become unstable while inducing. Otherwise, all the patients, they were getting blocks. And believe me, the blocks made the life very easy for the patients. The post-op delirium incidences came down drastically. The patient satisfaction improved like anything. So I start with my talk about perioperative pain management. See, if you look at in cardiac patients, it is a very important, very prophetic and profound statement by the ESC and ACC-AHA that inadequate analgesia is a modifiable cardiac risk factor. What does it mean? That a patient not having appropriate analgesia can be in difficulty. So the analgesia has to be appropriate for the patient. Now what inadequate analgesia does? It triggers tachycardia, hypertension. It increases the wall stress of the left ventricle and creates a prothrombotic state, and which can end up in perioperative myocardial injury. Here I would like to let you know that the perioperative myocardial injury and perioperative myocardial infarction, they are two different entities. When you talk about injury, there may not be any ischemic event, but if you check the cardiac troponin, you will find cardiac troponin is above 99th percentile. But when you talk about the perioperative myocardial infarction, it is associated with the symptoms, associated with the change in ECG and increase in the enzyme. So there is a difference between the perioperative myocardial injury and infarction. Now you see the incidence of myocardial injury after non-cardiac surgery. In one of the very large systematic analysis, review and meta-analysis, they found an incidence of 17.9%. That is in a population of cardiac patients undergoing non-cardiac surgery, 5,30,867. So it is not something very, you can just, say that it is not important. 18% is a huge, it's a very big incidence. Almost one patient out of 5 cardiac patients during perioperative period can have myocardial injury when undergoing non-cardiac surgery. Now this myocardial injury in non-cardiac surgery, there are so many studies, some 25 studies. They found that it is associated with 8.1% mortality in patients, those who suffer from myocardial injury, as against those who do not. And if you talk about the mortality at 30 days and at 1 year, still it remains high, 8.5% in those who suffer from injury and 20.6% at 1 year in those who suffer from injury, while those who do not, it is just 1.2% and 5.1%. So it is clear that the perioperative myocardial injury has to be taken care of, has to be avoided. Now, as I have mentioned, that what is responsible for that? It is perioperative myocardial injury, and the trigger of that perioperative myocardial injury is inadequate analgesia causing tachycardia, hypertension, prothrombotic state, and so on. Okay. So not only this inadequate analgesia associated with perioperative myocardial injury, it is associated with nausea and vomiting, impaired immune function, delayed wound healing, delayed discharge, psychological stress, and so on. Now see, when we talk about perioperative, what kind of analgesia you are going to give to a patient. There is no, one suit fits all, nothing like that. It has to be tailored for each patient. The reasons are that each patient is different, their social background is different, their level of education is different, the kind of disease with which they are coming is different, the type of surgery they are going in, that is different, and the pain history. Suppose some patient has gone under some or other kind of surgery before, and if the analgesia was not good during that surgery, the patient's reaction or patient's mental makeup will be very different than the one who has been given a very good perioperative pain care. So that also makes a difference in the kind of analgesia you are choosing for the patient. Now see, recently the Association of Anesthetists and British Pain Society, they came out with the concept of pain team. Like you see, many of the places you go, they have got a heart team. You go to the places, they have got, it's not, this is something that has, the importance, perioperative importance has gone up like anything. Now, who all are the members of the pain team? It's headed by the pain specialist, anesthesiologist is the member, surgeon is the member, and the nurses, they are the member. The reason being that you see what is happening to the patient, the feedback is given by the nursing staff. Hospital administration is a very important member of this pain team. The reason being that if the patient goes out of the hospital post-discharge, if the patient is not satisfied, naturally it lowers down the image of the hospital, and therefore the hospital administration is there on the board of pain team, and they ensure that whatever has been decided by the pain team has to be implemented. Psychologist is a member, and yes, the patient also, because you can talk to the patient and you can come to know that what kind of the intraoperative, postoperative, preoperative pain relief, etc. is to be designed for the patient. Now what the pain team does, so that you collect appropriate information. Because again, when I said, I just mentioned that every patient is different. Surgery is different. Patient's psychological makeup is different. Patient's background is different. So these are all the important information that is collected by the pain team. Now it is the responsibility to ensure that whatever the pain team, the kind of analgesia the pain team has decided for a particular patient is really implemented. It is the responsibility of the pain team to educate the staff. Reason being that you see when we talk to the patient, we say, दर्द हो रहा? हाँ भी हो रहा. कितना दर्द हो रहा? थोड़ा थोड़ा तो होगा ही. That is, you make the patient understand that you have gone under surgery means pain is a part and parcel of the surgery. No, it's not like that. You can make the patient absolutely pain-free. Just for example, I give you that spinal anesthesia, when you operate, the patient is absolutely pain-free. So same kind of conditions, by giving blocks and by giving appropriate analgesia, you can create in intensive care unit and in the wards, and you can make the patients journey in the hospital as if they have just come out for the whatever is wrong, but otherwise their life, their everyday was as good and as effective and as productive as it was before. Now you see, generally speaking, when we talk about how do you measure pain, visual analog score, that is the scoring system. But nowadays, what is being mentioned, that you don't go by the scoring system. You go by functional activity score. That is, you ask patient whether he can, the operated part, whether the patient can move that operated part or not. You talk to the patient, ask him whether he can take deep breath or not, whether patient can cough or not. The patient has to be able to perform all these activities without having discomfort. If the patient can perform all these activities, that means your level of analgesia is good. So I just mentioned about it. So another important 2 points that is there, that is anxiety and depression. Like morning we talked about, Takatsubo. See, many patients who are really very anxious and not willing at all, or they are really very, very fearful about the surgery, the pain, etc. It is the responsibility of the pain team to make them understand that, we are operating so many patients in this hospital every day, and everyone go back home. Everyone has they have safe and sound and comfortable journey. So for you also it would be as good as for others. You don't worry about. Try to reassure the patient, and that's the job of the pain team, to make sure that. And the involve patient, whatever the decision you take about the analgesia part, involve the patient. Some patients, they are, very, very, anxious, and they fear more. Now, what kind of analgesia you can think of it depends on the patient characteristics, comorbidities, pre-existing analgesia use, drug interactions, and the surgery being undertaken. Now, what is the basic theme? That aggressive prevention of myocardial ischemia, that is the most important thing. And you have to go for tailored multimodal analgesia and guideline directed cardiac therapy. You see, sometimes if suppose say your analgesia is not working well, you may have to go for beta blockade, you may have to go for the calcium channel blockers, and if necessary, if the patients are on statin or RAS blockade, etc., they have to be continued. Now, what are the drugs we use for multimodal analgesia? Paracetamol, one. NSAIDs, if they are acceptable. Now, the recent guidelines are saying that modest doses of NSAIDs can be used. Dexmed, yes. Ketamine, low doses. Lignocaine, low doses. Steroids. So these are out of these 5 drugs, at least 2 or 3 should be there while you are managing the patient intraoperatively. Regional analgesia block, whether it is neuraxial or it is peripheral block, has to be an integral part of anesthetic management. You cannot, you see, if you do not know how to give block, like if you talk to me, I have not been practicing block, but if you talk to me, I am to give anesthesia, I must understand and learn and practice regional analgesia. You should not, because you see, if you are an old man, like I am now 70-year-old, if I am to give anesthesia to a patient, if I am to undergo anesthesia for any surgery, I will choose an anesthesiologist who can give proper blocks and plus general anesthesia. Without block, no anesthesia for elective surgery. Now opioids, we talk about opioid-free anesthesia, opioid-free analgesia. Maybe yes, maybe no. If necessary, the patient should not be denied opioids, if necessary. But if you can manage without opioids, yes, you can. And now a lot of non-pharmacological things are also coming in, like music therapy, like having earplugs, reducing the noise level in the ICU, etc. So that all those kind of things also should be practiced. Now just, I will give 2 examples. Can I take 3 minutes more, 2 or 3 minutes? Can I take 2 minutes? Yeah, okay. So I will give just one example, a patient coming with a stable coronary artery disease, preserved LV function, and having intermediate risk abdominal or orthopedic surgery. The choice, it's a GA plus multimodal analgesia. Go for paracetamol, NSAIDs, low dose ketamine. Now ketamine low dose is just 1 to 2 milligram per kilogram per hour, not the anesthetic dose. It is just an NMDA receptor antagonist dose only. Or you go for low dose lignocaine, and as I have mentioned, nerve block, peripheral nerve block, or regional block, whatever is appropriate for the patient. Now another one is, suppose say you have a patient with severe LV dysfunction, ischemic cardiopathy, and going under for major lower limb surgery. A regional block is the primary method of anesthesia, no GA. It's a regional block, okay. You may go for spinal with opioids, or you may go for epidural with opioids. Avoid intubation related sympathetic surge and provide dense post-operative analgesia. These are important things. GA sometime in this kind of patients can actually, by making very big change in the preload and afterload, can cause very severe hypotension and jeopardize the myocardial health and create more problems. So these are the patients where the regional anesthesia, regional block, that is what can actually give a very good outcome for the team and for the patient and for the institute. Because you become something that, okay, yes, any kind of patient, difficult ones, bad ones, we are the ones, we can do it. So what I would suggest to that there is a need to develop pain team. It is different than the acute pain service. So with this, I stop here. Thank you very much. Thanks for your kind attention.